Pancreatic cancer. Look for a patient with painless jaundice, weight loss, and generally non-tender epigastric area. Amylase and lipids are mostly normal, while bilirubin, alkaline phosphatase, and gamma glutamine transpeptidase (GGTP) are elevated. CT scan reveals the pancreatic mass in 90% of patients. If CT is negative, the next step is an endoscopy ultrasound with biopsy of the pancreatic lesions. If CT scan shows a clear lesion in the pancreas, next step is surgical biopsy/removal at the same time. Now, pancreatic cancer cystic neoplasm of the pancreas are cysts that have small chance of turning into pancreatic cancer over time. Mucinous adenoma and intraductal papillary mucinous neoplasm are associated with elevated CA and CA19-9. Like cervical dysplasia, these neoplasms must be removed before the growth becomes invasive cancer. Also, like cervical dysplasia, the invasive malignant potential of cystic neoplasm of the pancreas ranges from 0 to 70%. There is no treatment for pancreatic cancer. Chemotherapy and radiation have little benefit. The 5-year survival rate is just 5%. Depression plus weight loss plus jaundice is equal to pancreatic cancer. CA19-9 follows response to treatment of pancreatic cancer. Liver disease. All forms of chronic liver disease can produce ascites. Coagulopathy. All coagulating factor receptor 8 are made in liver. Asterix and encephalopathy. Hypoalbuminemia and edema. Pyrangiomatous and pulmonary portal hypertension leading to varices. Thrombocytopenia from splenic castration. Renal insufficiency, hepatorenal syndrome, and hematopulmonary syndrome. These all CLTs can produce these stuff. Everyone with cirrhosis should get an oral ultrasound every 6 months to screen for cancer. Ultrasound 95% sensitive for detecting cancer. Ascites. Paracentesis should be performed if there is new onset ascites, abdominal pain, and tenderness or fever. Portal hypertension from cirrhosis is the etiology of ascitic fluid if there is a low albumin level in the fluid. Serum ascites albumin gradient SAAG is the difference or gradient between the serum and ascites. SAAG greater than 1.1 is highly suggestive of portal hypertension. SAAG correlating level with disease. Less than 1.1 grams per liter is infections, SPP, spontaneous bacterial peritonitis, cancer, and nephrotic syndrome. Greater than 1.1 grams per liter is portal hypertension, congestive heart failure, hepatic vein thrombosis, and congestive pancreatitis. Remember ICN. ICN is less than 1.1. Infections, cancer, nephrotic syndrome. Less than 1.1 grams per liter. Here 1.1 gram per liter PCSC. For hypertension, CHF, hepatic vein thrombosis, and chronic pancreatitis. Remember ICN. ICN less than 1.1 gram per liter of ascites, salt. Spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is infection without a perforation of the bowel. How the bacteria gets there is unknown. Causes include E. coli most common, anaerobe pneumococcus or respiratory pathogen is unknown. Diagnostic testing includes cell count with greater than 250 neutrophils, best initial test, or is the base upon which we will start treatment. Gram stain almost always negative. LDH level 2 non-specific. Fluid culture most accurate test, but results are never available in time for treatment decisions. Or viral bleeding with ascites need spontaneous bacterial peritonitis prophylaxis. Treatment of spontaneous bacterial peritonitis is the ceftriaxone or ceftriaxone. SBP frequently recurs when the ascites fluid albumin level is quite low. Prophylactic prophylaxis or thiamantoprim, sulfamethoxazole is used to prevent spontaneous bacterial peritonitis. If the ascitic fluid albumin is less than 1, prophylaxis against SBP is also needed. This is why everyone with new ascites needs a paracentesis even if there are no symptoms. Anyone with spontaneous bacterial peritonitis needs lifelong prophylaxis against recurrence. Treatment of specific features of cirrhosis. Feature treatment. Ascites and edema, spironolactone and other diuretics, serial paracentesis for large volume ascites. Coagulopathy and thrombocytopenia, fresh foreign plasma and platelets only if bleeding occurs. Encephalopathy, lactulose and rifaximin, hypoalbuminemia, no specific therapy, pyrangiomatous and pulmonary edema, no specific therapy, varices, propranolol and banding through endoscopy, hepatorenal syndrome, somatostatin, octreotide, and midodrine, hepatopulmonary syndrome, no specific therapy. Acute alcoholic hepatitis. Look for jaundice, anorexia, and weight loss over a few months with right upper quadrant pain ascites, liver tenderness, and fever are often present. Also look for AST is greater than ALT, elevated GGTP and bilirubin, elevated iron and prothrombin PT. You must exclude viral and drug-induced hepatitis if the discriminant factor is greater than 32. Treat with steroids. Discriminant factor is equal to 4.6 into patient PT and minus control PT, prothrombin plus bilirubin. Severe alcoholic hepatitis has 50% mortality. Petropulmonary syndrome, this is lung disease and hypoxia entirely on the basis of liver failure. Look for orthodoxia, this is hypoxia upon sitting upright. There is no specific therapy. As the liver's condition is this bad, the patient needs a transplant. Causes of cirrhosis, alcoholic liver disease. This is a diagnosis of exclusion. The most accurate test, as with most causes of cirrhosis except cirrhotic pancreatic, is a liver biopsy. Alcohol, like all drugs causing liver disease, gives a greater elevation in AST compared to ALT, while hepatitis gives a higher ALT than AST. No, alcohol liver disease greater than AST. S for alcohol liver disease greater than ALT. And greater than LT is seen in viral hepatitis. L Sophie, viral hepatitis ALT greater than AST. Binge drinking gives a sudden rise in GGTP. There is no specific treatment. Primary sclerosing cholangitis. Answer primary cholangitis. Answer primary biliary cholangitis. PBC as the most likely diagnosis when described as woman in 40 or 50 years. Fatigue and itching. Normal bilirubin with an elevated alkaline phosphatase. Most characteristic features of primary biliary cholangitis are anthelasma/xanthoma, collection of cholesterol under the skin that is yellowish in color, and osteoporosis. Diagnostic testing includes liver biopsy most accurate, any mitochondrial antibody most accurate blood test, bilirubin and IgM elevate in very advanced stages. Treatment is also deoxycholic acid or obeticholic acid to decrease fibrosis. Now these are for treatment of PBC, primary biliary cholangitis. Also deoxycholic acid or obeticholic acid. In primary PBC, primary biliary cholangitis, obeticholic acid decreases fibrosis. Primary sclerosing cholangitis. Over 80% of primary sclerosing cholangitis occurs in association with inflammatory bowel disease. Look for pruritus, elevated alkaline phosphatase, and GGTP, as well as elevated bilirubin level. Early primary sclerosing cholangitis can look just like PBC, primary biliary cirrhosis. Bilirubin level can be normal in early disease. Diagnostic testing includes MRCP or ERCP. Most accurate test shows bleeding, narrowing, or strictures in the biliary system. MRCP is generally done because there is no therapeutic need for ERCP. Biopsy only done for other reasons that is not essential for establishing a diagnosis. No treatment is effective for primary sclerosing cholangitis. We try to dilate stricture, but nothing modifies the disease. Primary sclerosing cholangitis is the only cause of cirrhosis for which a biopsy is not the most accurate test. Tip: primary sclerosing cholangitis. It does not improve or resolve with resolution of IBD, inflammatory bowel disease. After a colectomy or colitis, the patient may still progress to needing a liver transplantation. Alpha-1 antitrypsin deficiency. Look for the combination of liver disease and emphysema, COPD in a young patient aged less than 40 who is non-smoker. The question may throw in a family history of COPD at an early age. Treat by replacing the enzyme. The most frequently asked question is why? What is the most likely diagnosis? Inhaled aerosolized alpha-1 antitrypsin is used for lung disease. Hemochromatosis. This is a genetic disorder leading to overabsorption of iron in the duodenum. The mutation is the C282Y gene. Men present earlier than women because menstruation delays the onset of liver fibrosis and cirrhosis. Hemochromatosis may be found on routine testing with mild abnormal LFTs or iron levels. Look for patient aged 50 years with mild increase in AST and alkaline phosphatase and fatigue and joint pain, pseudovote, erectile dysfunction in men and amenorrhea in women from pituitary involvement, skin darkening, diabetes, and cardiomyopathy. Now, Vibrio vulnificus, Yersinia, and Listeria infections occur in hemochromatosis because these organisms feed on iron. With diagnosis testing, iron study best initial test shows increased serum iron ferritin and decreased iron binding capacity. Liver biopsy for increased iron, most accurate test. EKG may show conductive defects. Echocardiogram may show dilated or restricted cardiomyopathy. Remember, while vulnificus V, Y, and L, VIL infections occur in hemochromatosis, the organisms feed on iron. Here's a scenario: a 54-year-old man is evaluated for fatigue, erectile dysfunction, and skin darkening. He is found to have transparent saturated iron divided by TABC greater than 50%. His AST is 2, while upper limit of normal, with the next confirmed diagnosis. C. Abdominal MRI and HFE. C. 2825Y gene testing, because the skin darkening shows hemochromatosis. MRI shows increased iron deposit in the liver. Abnormal MRI combined with the abnormal genetic test for hemochromatosis can prepare the patient the need for liver biopsy. Hemochromatosis has an association with diabetes, although glucose levels will not confirm a diagnosis of hemochromatosis. Prussian blue is a stain of blood cells for iron used to diagnose sideroblastic anemia. Treatment for those with overabsorption iron is phlebotomy. Liver fibrosis can resolve if phlebotomy is begun before cirrhosis develops. If phlebotomy is a contraindicated or a parent is anemic and has hemochromatosis or overtransfusion, example thalassemia, use iron chelation therapy with deferoxamine, deferriprone, or deferoxamine. Deferoxamine and deferriprone are huge breakthrough medications because they are effective orally. Deferoxamine must be given lifelong by subcutaneous injection. Oral iron chelators are deferriprone and deferoxamine.